Okay, thank you very much for inviting me to speak. Can you guys see my screen?
Yes.
Okay, wonderful. So I'll talk about the liver findings in COVID-19. Some background: abnormal liver function tests are common in COVID-19 infection, and data out of China suggests that the LFT abnormalities correlate with the severity of pulmonary disease. There's very limited pathologic description that came out of China. One paper described macrovesicular steatosis, which is a very uncommon pattern of injury seen mostly in Rise syndrome or acute fatty liver pregnancy. The picture that accompanied that description didn't really show that, in my opinion. Showed the more common macrovesicular steatosis, which we see in fatty liver disease. And the histology has not been described in allograft livers, which is, of course, of great interest in our medical center. Okay, so I'm going to report on the first 27 autopsies that I have reviewed in detail, and my colleagues have as well. One of those cases actually is a liver allograft recipient. And I'll say up front that I'm partnered with Dr. Betsy Verna in hepatology to clinically characterize all these cases, and that work is really still ongoing. So there are a lot of ClinPath correlations that need to be determined and may be sort of interest, but I have to say that of interest to the audience, but I have to say that that work is still ongoing. I'll give you the take-home points up front. Acute or lobular hepatitis is common. Portal inflammation is rare and not entirely sure what the significance is. Macrovesicular steatosis of the type that we see in fatty liver disease typically is very common. It likely relates to stress, poor lipid oxidation in the setting of systemic stress. Again, the vascular findings are rare, subtle, and that's excluding common perimortem changes like shock liver and congestion. The biliary epithelium has been normal in every case, which is of interest because of the distribution of the ACE2 receptor, which is highly expressed on biliary epithelial cells. And there have been a few odd N of 1 type findings, which we'll touch on just very briefly. Okay. Acute hepatitis. So acute hepatitis is characterized by hepatocyte apoptosis and lobular necroinflammation. And we see those changes in these pictures. Here we have an area where the hepatocytes have dropped out, and you see some lymphocytes and empty space where there should be cords of hepatocytes like we see here. On this side, we see a single apoptotic hepatocyte. This is not normal. This is a sign of acute hepatitis, though this is fairly subtle. Nonetheless, some degree of acute hepatitis was present in 60% of the autopsies that I've reviewed. Steatosis was present in 81% of the cases, which I think is beyond what you would expect based on the obesity data. The other interesting finding is that it was often azonal or panlobular. So usually steatosis in the liver starts in zone 3, which is the part furthest away from the portal tract. And even in cases with only a little steatosis, we would see the fat adjacent to the portal tracts, as you see here. So probably, like I said, this is due to faulty lipid oxidation. Only 2 cases had frank steatohepatitis, so I assume those 2 probably were pre-existing. As for the thrombotic findings, they were rare, only 3 cases, but here's an example where the sinusoids have been gummed up by thrombotic material. One case had non-necrotizing portal and lobular granulomas. Here's the portal one. In allografts, we reported the first example of hepatitis that we thought was due to COVID-19 in an allograft. And this was a baby who received a transplant from her mom. And basically a few days after transplant, they both developed symptoms of COVID and had positive PCR tests. And you can see if we just look at the blue, which is the ALT, post-operative day, it was trending down the way you would expect. On day 4, she tested positive for COVID, started having mild symptoms. By day 6, she had chest x-ray changes. And look at that, the ALT basically 5x'd. And here is an image showing a lobular hepatitis. These are all apoptotic hepatocytes. This is probably a group of, I don't know, 20 or 30 hepatocytes that died. It's really much more severe than what I showed you in the earlier, from the autopsy cases. So it brings up the possibility that perhaps the immunosuppressed patients have a more serious hepatitis. Anyway, the major pathologic findings: fatty liver, acute hepatitis, vascular disease is rare, biliary disease not present. A lot of questions remaining, including what I just mentioned about the immunosuppression, presence and amount of virus in liver itself, and the range of hepatitic findings. Thanks very much.